You don't have to solve every problem that walks into the urgent care. That is not our job. Think of us like traffic directors. You're in P-Pal here. Welcome to another conversation from the track. So today's conversation, I want to talk about doing too much in the urgent care. All right. So if you've been following my journey, watching my other videos, then you'll know that I started my NP career in the urgent care. And so I was very busy, got thrown out there, and I worked there for 3.5 years straight. And then I left, and the next part of my journey was my version of the Odyssey. I went and worked a bunch of different places, had multiple jobs simultaneously, working as a contractor, showing up at different kind of clinics, the occupational health, ER, primary care, even direct like house calls. So I've seen a lot. And just over time, with experience and time in, when I came back into the urgent care, I had a whole different perspective. And so I had seen a lot, worked in little basic places where they didn't even have like a UA machine. Like all they had was like a dipstick, and that was the only test they had in the whole place. And I also worked in places where they did IVs, and they actually have morphine, and so it functioned as like a mini ER. So I worked in these settings and kind of everything in between. So when I came back, I had a different framework. So I observed a lot, and the way that I approached patients was different. So not only did my framework change, but also I worked with different types of providers. And so just kind of an average, I narrowed it down to there's like 3 different type of providers, right? And how they practice. So the first type I want to talk about is the anxious provider, right? So this is the person that thinks the worst case scenario in everything. So the anxious provider typically is they're going to order more tests, they're going to send more patients to the ER, and they're going to overprescribe because they have that fear of missing something, okay? So that's the first. And then the second type is the arrogant provider. Now, this is the person that, supposedly they have all of this experience, they have all these grand stories of all the things that they used to do. Oh yeah, I used to, put IVs in on a helicopter and do all this stuff. And this person is the fixer, right? They feel like they have something to prove. And so a lot of times what will happen is they will keep a complex patient in that setting because they have something to prove, like I can take care of that here. And sometimes you cause more problems doing that, all right? And then the last type is the person that just accepts responsibility, right? So every thing that the patient complains of, they can have 13 complaints. You just feel like, oh, well, this is the problem, I have to take care of it. And I know I definitely started that way, and I think a lot of people do start that way as well, because it's like nobody really, like once you get out of school, and if that's your first job, they just throw you out there. So in my first video, I talked about, your first job is your actual residency, so you don't get the whole how to do this thing. And so that's basically what I want to talk about in this video today, okay? Because we all know, we see everything in the urgent care. And a lot of times, we may be the first time they are seen for this problem. And the problem could be going on for months to years. And today's the day they decide to finally come in. For instance, one I see a lot is like rectal bleeding. And it's always like 11, 12 months it's come in, and they've seen nobody. And then all of a sudden they decide to do it today. So, of course, we start thinking about all the potential causes, and a common test that was frequently used is the Hemocoat. Now, if you look at the new evidence and things like that, people are really starting to move away from doing that because you get a lot of false negatives and then you get false positives. Not only that, if somebody's having rectal bleeding, they should 100% get scoped, all right? Now, there's not a GI on this planet that will have a patient with rectal bleeding and not scope them. I saw GI last month for like chronic bloating I had, and he was like, yeah, we're gonna do a blood test, we're gonna do a breath test, and let's just do a colonoscopy. So you're going to send them out anyway. So why do you need to put your finger up there and even go through that process at all? So that's something that you don't necessarily have to do, okay? And then a lot of these common diagnoses and complaints that we see, a lot of them are clinical. For instance, like a concussion. A concussion is a clinical diagnosis, right? That means you can diagnose that based on their complaints and the history and exam. If somebody hit their head or they fall and they, whatever the mechanism is, if they hit their head, they have a headache, they have dizziness, blurred vision, light sensitivity, that's a concussion. I don't need a CAT scan to tell me that. A CAT scan is going to rule out a brain bleed. That's when you need to send them to the hospital. But most of the ones that we see, the walkie-talkies that come in there, you don't necessarily have to do that. Okay, so there's a lot of these common complaints where they just come in and it's like, if you're fearful or just, oh, I can take care, and you'll just order all the stuff and it's really unnecessary, okay? So when I say we're like traffic directors, a lot of this, because I've worked ER as well, but I spent more time in the urgent care. And yes, there are differences, but the thing with the ER is like, you have the resources and the tools to actually do something about it. Urgent care, you're very limited. Like, I know what I would do if I was in the ER, but I can't. And then you have to decide, it's like, well, are they sick enough to go to the hospital right now, or is this something where a follow-up? So that's actually what makes urgent care a little more challenging, okay? So it's not just, you know, accepting responsibility and taking on all this stuff and ordering all these tests, but it's also not letting, you know, somebody that could have a problem just kind of fly by and just slide through without you addressing certain things. So I have another video when I'm talking about the white coat hypertension. The point of that whole video was basically just saying how patients will use that as a convenient excuse. And then I was just basically telling providers, don't just accept that, especially if they've had multiple instances where the blood pressure is high. Like, don't just accept that excuse, because you're basically just letting all these patients just go past you, and they really need to be on medication. They actually have high blood pressure, okay? So you don't want to miss something serious, because what if it is, you know, like somebody that's sick and all of their stuff is negative and they just don't look right? And what if they could have HIV? You know what I mean? And so you're just kind of letting them slide through. So this is why the interview portion of the entire evaluation, I think that's the most important part, okay? So even though they told the front, even though the MA, the tech, whoever has done the little triage or whatever, I still start over. So tell me what happened. Yes, you're going to have the ones, oh, well, I already told the nurse, well, I already told the story. And I let them say that. So I want to hear from you. Tell me, I'm the person that can actually do something about this. So let's hear it one more time. Because again, they may connect the dots in their mind, or they'll tell you what they think is going on and things like that. But give me the story, let me filter, and I will decide what needs to happen, okay? So, because it's like a lot of energy is spent, you know, over ordering certain tests or working up certain patients, and then we just let other patients just kind of slide by and just kind of get through, okay? So we have a very big responsibility and role in the urgent care, because we see everything, because we know so many people don't have a primary doctor, and we know how expensive ER doctors are. That's why they come to us. So we see everybody, from kids all the way to 90-plus-year-olds. We see them all, and it's cheaper than a hospital, and it's convenient. They don't need an appointment. So another thing is, like, a lot of missed opportunities happen in this setting. So we have to be a little more diligent. Definitely, even if you don't order a bunch of stuff, at least spend that time talking to them. At least gather as much information as you can. And then, but also, you know that the urgent care is limited as far as resources. So I spend more time talking to them, but I'm also filtering out, okay, this is too much for here. So again, I may not be able to order the test there, but I know where they need to go. I know where to send them. Okay, well, this is an urgent care. And again, I always remind patients, okay, like if they have, 13 complaints, oh, my back hurt, my neck, I get dizzy on Saturdays, my right knee hurts, what was it that brought you in today? Okay, like, I know this has all been going on, but what changed today? All right, so again, you don't have to work everybody up. I'm actually discouraging that. But you do have to have an internal filtering system where you know, like, what's important, what can wait, what can I not miss? Because another thing, while all this time is spent unnecessarily working people up or unnecessarily sending them to the hospital, again, we could let an HIV patient just walk right by you. So definitely get a good history, okay? And again, use referrals. That's what they're there for, okay? But if they're coming back, of course, we always give return precautions. Hey, let's try this. If this is not better, come back. But after the second time and the first treatment didn't work, I'm definitely already thinking about it, but I'm going to go ahead and plant that seed. I'm going to do this other thing, but if this doesn't work, then you need to go to a specialist. So I'm probably still going to put in a referral on that second visit, just because, and I already tell them, because a third visit, and this is not a workers' comp case, this is just some problem. Usually it's like derm, you know what I mean? Because derm is definitely tricky for everybody, okay? So I don't want them to come back. Like, after a second time, I don't want you to come back here, because obviously we've exhausted the resources. Because really, think about what you can actually do for a derm problem. Infectious, it's allergic, or it's a fungus, okay? You're going to do some steroids, topical, oral, you're going to do some antibiotics, or you're going to give an antifungal. That's really it. But I mean, if it's done after 2 visits, they don't need to come back here. So that's why I say direct traffic. Any GI bleed, send them out. But anything chronic, kind of long, okay? Like, you don't have to do all of that stuff. And then, like, for sick visits, right? We know this stuff is viral. So everybody don't need a flu, COVID, strep. If you have RSV there, and then you sending out a respiratory panel. Why are you doing all of that? It's too much. It's a virus. Now, again, only time I'll do a respiratory panel is if it's like a young child, and usually the parent is pressing. You just have this, I just need to know. Okay, I'll do it if they ask, but I'm probably never just gonna order that. Unless it's something weird, unless they've already been seen, they've been treated for something, then I will, just to kind of, but that's very rare. I just, because why are you ordering this stuff? Okay? It's the same thing like the abdominal ultrasound, which I talk about in my abdominal pain video. Don't just order tests and then hope you find something. Like, that's not good practice. So the history. Because by the time the conversation's over, you should already know what you're going to do. And I'm not saying you're going to know the answer. I'm just saying you know how you're going to proceed. Because really, the exam may or may not give you additional information. Most of the time, it doesn't. Like, I already got everything I need to know from this interview. So that's why that is honestly the most critical part of the entire visit. Okay, so just make sure that you ask questions. And so, again, we weren't taught any of this. You're taught certain things, but not how. We're not taught a framework in school. And so that's why this is important. That's one of the reasons why I do what I do. Okay, so I hope you found this video helpful. If you are an early career if you are early career NP and you need some assistance or just struggling with confidence, I did create a clinical confidence starter pack, and I will put the link in the description below. And again, if you are interested in my videos, then I put out content every week, and so follow along. And I hope this video was helpful. Your NP Pal here. Practice boldly, and I will see you on the next one.